Thank you. Session of What's the Big Idea? We're going to have Dina, Eric, and Michael talk about optimizing our approach with government agencies, the war on bugs, and the new efforts of Pfizer's outreach. So over to you, Dina.
Great. I am taking a very different approach today. It's a lighter approach, and it's also sort of borrows from the saying that there aren't any big new ideas. It's really a repurposing older great ideas. So today I'm going to talk a little bit about big government and big business, and sort of either optimizing that approach, but a more colloquial way of talking about it is making the marriage work for the sake of our patients. Because of the Affordable Care Act, 157 new government agencies, commissions, and panels have been established. So we talked, Megan yesterday talked about big government and the bureaucracy and what that does about individual choice and individual sort of approaches. So I'm here about how does Pfizer stay effectively engaged with 157 new agencies, and how do we leverage our scale? And what I mean by scale, it's a very businessy sort of way of talking about it, but how do we take all the great intellectual capital that is Pfizer, the really smart people, the really great work around our products, the really great science that we have around talking with patients and working with physicians. So how do we take that very businessy-like term, which really means an enormous girth, again, of intellectual property to achieve our public policy goals? How do we continue to address patient needs? How do we continue to protect physician choice and ability to individualize care? And also, how do we advance and continue to protect innovation? We are a for-profit model, and we got to do that. Now, you might say, who is this guy on screen? Is it that guy that left public policy 2 years ago? Is it someone that used to head up R&D? No, that's actually Dr. Phil, Oprah's Dr. Phil. And I thought it was only apt when we talk about relationships that we should go to Oprah, who addresses and helps people across the United States. We should go to her go-to guy and find out what he is telling us about relationships and what can we learn. I think that all of us sort of forget at times that we're always individuals working with individuals. We talk about entities and government agencies, and those agencies and our company are made of people. So, Dr. Phil, what do you tell us about relationships? He talks to us about 10 myths, and he talks about relationships and busting those myths. So the first relationship myth is a great relationship depends on a great meeting of minds. What I find interesting about this is he said that actually trying to blend very disparate viewpoints is actually corrupting. He says you don't want to blend all your perspectives. That's not a good thing. So what I suggest that we do, and it's been said over and over yesterday, we keep hearing it again today, that the great meeting of minds is really finding that common vision. Yes, we have ROI on one side and we have cost on another, but underpinning all of those is patience. So we all have to be able to pull those very important tenets and pull that patient thought into the center of our bullseyes. The other relationship myth is a great relationship requires a great romance. Now, we know passion is not a sustainable thing unless you're coming to work at Pfizer where your passion is endless. But the passion is really grounded in having deep connections. And deep connections with other people that you collaborate and work with are based on very honest conversations about what you do and why you do it. And this is where I suggest transparency comes into play. People know me at Pfizer that I work on the pain of transparency, and it's sort of a corrupting way to think about it. Transparency is really putting your opinions on the table and letting people know why you think that way and being very clear on why you think that way. So this myth can be addressed with our really having transparent conversations. The third myth is a great relationship requires great problem solving. Now this is where I and Dr. Phil, who am I to disagree with Dr. Phil? But Dr. Phil believes that 90% of relationship problems are unsolvable. And I find that it goes against my passionate, enthusiastic self that is, not possible. You can solve things. But I think that we need a lot more We need different types of problem solving. We need a different toolkit. We go to our government partners with a standard toolkit. We go to them with written comments. We go with them with briefings. We leave our little one-pagers. That's not sufficient. Complex problem solving has to happen a lot more quickly. We have to be a lot more adroit. And back to the question, Greg, you asked this morning, what do we need to do different? We have to get those different voices to the table. And as Jim described at our keynote at dinner, we need to be the catalyst. We have got to provide those forums where this new kind of problem solving can happen. Is Health Affairs the appropriate venue where Pfizer sponsors a call-in number where people with, that are wrestling with policy questions can call? We can get them hooked up with academics. So I really believe that this particular myth is the one we need to bust. I don't agree with Dr. Phil, and we certainly can do a lot better in using social media, online forums, and a lot of public third parties that can help us sort of bring all these new voices together. The relationship myth number 4, a great relationship requires common interests that bond forever. It is not activities that bond. It is vision. And I can't emphasize enough that we have to define what it is what we mean by patient value. I love the conversation yesterday that we're not talking enough about societal value. Let us have that value discussion. Let's align on that, agree on that. Then we can better problem solve. And then let's start talking about costs and how the parties might want to partition that and how do we share sort of in the cost of that. But again, it's not the activities and it's not about the hows, but the whats. Relationship myth number 5, a great relationship is a peaceful one. Well, I want to say in healthcare, it is not a peaceful relationship. It's a very spirited, emotional debate. Dr. Phil again says debate is good, but it has to be anchored in respect. And the debate actually is very healthy for relationships because it gets out stress, it gets out your perspective, you're being heard, and it's also very transparent. So it also builds trust. So let us not walk away from spirited debate. It might get a little messy and a little ugly, but let's stay engaged, and let's stay engaged in a very positive way. And that leads me to myth number 6. A great relationship lets you vent all your feelings. I know that this is about what Pfizer could be doing differently, but I'm going to put this slide out there on our critics. Words matter. They're using very charged language. That language gets picked up by our patients. They're actually driving a wedge with our patients in our company. And I believe, I don't see Antimicrobial in here, but I absolutely support, all her work and thinking about how do we change that debate. Because we can have politicians using us as their political chit, calling us the profiteering, monsters. Because I really believe that they don't quite understand the unintended consequences of using that kind of charged language, and whatever we can do to change it, I think would be absolutely brilliant, and we as an industry really have to chip away at that. It just doesn't help anybody. Relationship myth number 7, a great relationship can do without sex. So I kept this in here for the sake of completeness, because I didn't want to short Dr. Phil, but I also wanted to remind everybody that certainly Viagra is a very successful product of ours, so I think that we sort of get this myth, and I say no more. So relationship number 8, a great relationship cannot survive a flawed partner. I will tell you that an awful lot of our critics think that we're a very flawed partner. It is very difficult when you're looking to medicine and access to medicines as a social good, and we're a for-profit company. That is a real, tension, a real relationship breaker. But I'll remind people that everybody can survive flawed partners. And as flawed as we may be, I think we definitely have fabulous examples where for-profit companies have made unbelievable, enormous strides, for-profit incentives in helping people in public health. And we need to remind, again, that as part of the vernacular, we have to remind our partners and agencies and, anybody in the policy debate that that's indeed a truism. And then relationship number 9, myth, is there's a right way and a wrong way to make a relationship great. And I think we as a company absolutely own this one. We espouse and absolutely believe that there is no one way to practice medicine. There's no one medicine for, it doesn't take just one medicine. You need 3 or 4 statins. So I think we have to continually remind people that there is no one way in medicine, and keeping those choices alive, that innovation is incremental, and whereas they may not think alleviating one side effect is a big deal, it is a very big deal in the larger ecosystem of innovation. And we've got to keep that going, and we've got to keep those ideas alive. And then the last myth is your relationship can become great only if you fix your partner. I've been working on my husband for years, and I've accomplished absolutely nothing. So this gets back to, you can never fix anybody, but you can fix yourself. And we can only fix ourselves. And not to sort of have maybe an old Pfizer posture would be, well, if we say it enough and we say it articulately enough, they'll believe it. But sort of those days are gone. We have to talk a little differently. We have to posture and work with partners very differently. So that gets down to my concluding slide. What does Dr. Phil really sort of say to us in the policy world and how we operate? I'd say we need a different toolkit. And with that different toolkit, I think we can accomplish enormous amounts. One is constantly reminding people of what our shared goals are, and do we go further to even have a common definition of patient and societal value. Problem solving, we all need to participate very differently. I think the key to good problem solving is to get a lot of different players at the table, but when they're actually there, actively listen, understand those perspectives, and make sure they're a big part of the solutions that we offer. And lastly, let's not shy away from the public discussion. And again, we talked about relationships are messy. Yes, the relationships are going to be shouty. That's fine. But we have to accept all those, not shy away from them, and really have transparent conversations. And that's where I leave it. That's Michael.
Okay, we'll find it. Good morning. I'll let you know that I'm hearing impaired, so I need to read lips. So if you ask me some questions, I'll need to see you. But with the lights in my eyes now, I can't see either. So what we may have to do is I may have to approach you when you read questions. It is not an attack. Do not fear. I simply want to be able to understand what you're trying to ask me. Okay, well, I've decided to pick something that's near and dear to me, antibiotics, microbiology, and use that as a parable to talk about value of pharmaceuticals, value of drugs. But before I do that, I want to use an analogy which I think really fits, and that is really starting with the quote from one of my favorite movies. The quote is, "Failure is not an option." And the quote's from the movie Apollo 13. And it reminds me of the Apollo program. I grew up in Cocoa Beach, Cape Canaveral, Florida, so I watched all those launches. And the space program really captured the imagination of college students, high school students, children, and it really made us want to go into fields that are technological. The number of PhDs and advanced engineering degrees during the Apollo era in the 1960s was very, very high. And that's simply because the nation had a vision, and we had a goal, and we believed in the goal. You ask anybody if we wanted to go back to the moon today, it would take us 20 years. Well, when JFK said we're going to the moon, we were there in about 6. And we had to develop all the infrastructure, all of the technology to get us there, where it didn't exist before. What's different between then and now is the human capital and the knowledge capital is not there Those scientists who put us on the moon retired. The emphasis on space travel disappeared. So people went into other areas and other fields. There is a very, very close analogy between that and drug discovery. This slide is essentially looking at the history of antibiotic research. And in the original, I guess I won't need to use the pointer. Look at the start of the slide. We have sulfa drugs, and we have some of the para-amino salicylic acid type drugs. Those were originally discovered in the 1920s and so forth. And really that opened scientists' eyes because for the first time we had external substance that could actually cure disease. This was something that was really, really revolutionizing to the way we thought of medicine. Because instead of amputating, we could give an external substance and cure the infection most reasonably. The discovery of penicillin in the 1940s was essentially by accident, some sloppy science by a sloppy physician. Alexander Fleming, I'm sure he wouldn't like to be spoken of in those terms, but essentially looking at contaminated plates, contaminated with a fungus, that fungus producing a substance called penicillin inhibited the bacteria he was trying to grow in his culture. And that's essentially where we got penicillin from. Of course, it took a lot of know-how and a lot of engineering and a lot of science to scale that discovery up to something that was therapeutically useful and could be used in the clinic. And that really launched the whole era of antibacterials from the 40s through the 60s. A lot of excitement. Many people were becoming microbiologists. Whole universities, the University of Wisconsin, for example, built their reputation on producing great microbiologists who would go out and help cure a lot of these diseases. It works so well. Antibiotics work well. They rarely fail to do what they're supposed to do. They work so well that in 1963, the Surgeon General of the United States essentially said, we have won the war on infectious diseases. We need to look elsewhere. That opinion was echoed throughout the medical community. We weren't envisioning drug resistance. That, coupled with vaccines, essentially raised the lifespan of this country in the 20th century 30 years. Of those 30-year increase in lifespan, 25 years is directly attributable to improvements in public health, of which includes vaccines and antimicrobial intervention. So we've won the war on infectious diseases. Drug companies began to stand down. If you look at the timeline now, as we get to a clavulanic acid in the mid-1970s, look at that gap. I mean, that's very astounding. We decided we weren't going to do this anymore. The war has been won. There's no money going to basic research in academia. The academics want to get other grants in other areas, such as allergies and cancer and those sorts of things. So we detooled, just like the Apollo missions, just like the fact that we're sending engineers to aerospace museums to look at parts in museums and figure out how they were made for the original Apollo mission. That's a true story. We forgot how to do this. As soon as we realized we were wrong, time to retool again. In the 1980s, we saw another resurgence of antimicrobial development, but then it was few and far between for a variety of reasons, slim pickings. A lot of the easy stuff had already been done. It's getting more difficult, and as it becomes more difficult, it becomes more expensive and becomes more time-consuming. You see the next slide, which is also an eye-opener. If you look at the very early discovery of sulfonamides, penicillin, moving down to today, I really wish I had a pointer here. But
Yeah, I'll keep my hand out.
I can get this thing, oh, here we go. I couldn't see it because I was being blinded by the lights here. But here we go. All right. First thing when I first saw this slide, there's a lot going on here. And a lot of it we don't understand yet. And a lot of folks within Pfizer and elsewhere are trying to figure out, this is an observation of what's happening. If you look at them in the early antibacterials, this breakpoint here, 1965, mid-1960s, in terms of when it was discovered to when we began to see clinically relevant resistance, is what this slide is saying. Over the years, if you look at most recently, after 65, with maybe a few exceptions, all the new drugs, discovery, resistance, that the lifespan is becoming shorter and shorter here. As a matter of fact, linezolid, which is Zyvox, which is Pfizer antibiotic, it's hailed as being the first new classic antibiotic in the last 35, 40 years. In the laboratory, we saw resistance to linezolid before it reached the market. Okay, think about that. We saw resistance to these antibiotics before they were being used in the clinic. Okay, you ask yourself, how can that be? Well, see, these bugs are smart. They don't forget. The mechanisms that they built up becoming resistant to here only need to be tweaked a little bit to bring resistance to the new drugs that are coming out. Not that these are copycat drugs, but there's essentially building a machine, adding different parts to the machine, like upgrading your computer. Instead of buying a new machine, you upgrade a hard drive or you do something of that nature. That's the same thing that's happening here. These bugs are learning. The selective pressure is increasing. Now, something else that occurred to me, now I have no proof of this. All I know is that in 1965, we had Medicare and Medicaid, which increased access. Now, another thing you need to remember with antimicrobials, which is very different from anything else out there, is that these drugs become obsolete the moment they're used. Unlike something like Lipitor, where we're not going to see the patient become resistant to Lipitor and render it ineffective, as soon as you use an antibiotic, you're going to generate resistance. That's natural selection. That's a universal law. That's the way it works. So we're going to see resistance. We can help the speed of the resistance through stewardship, effective use, those sorts of things. But resistance is inevitable, which is why we cannot rest on our laurels here, which is why we need to continue to make new antibiotics. It's not because we're interested in making money. Of course we are. That's the nature of the game. But these bugs are going to beat everything we throw at them. This slide simply looking at a timeline with the companies getting out of antimicrobial research. In 1980, 36 US and European companies were doing antimicrobial research. That number has shrunk now to 7 large companies and a host of small biotech that are still looking at antibiotics. Why? It's becoming more and more difficult to make them. Number 2, the inevitability, the fact that we picked all the low-hanging fruit, if you will. It's becoming more difficult to find a molecule that's exceedingly toxic to an organism that's invaded our body without hurting us. And in many cases, it will hurt us if we take it long enough. Nobody wants to take chlorphenicals for 6 months. All right, these drugs are not made for that. These drugs are meant to be taken for an acute period of time. So the issue of safety benefit here is important to understand. We don't do a very good job explaining it. Benefit risk. All right, that's something we can be doing a little bit different. Again, this is another example. In the mid-1980s, we had 16 approved new antibiotics. 2003, 2007 time period, we had 3. Once again, companies are getting out. The knowledge capital is disappearing. People are not going to school to become microbiologists anymore. They're going to school to become something else. Cardiovascular people, whatever. But the point being, as the public loses support, the government withdraws its support, academics don't do the work, they can't get grants, they move on to something else, you begin to lose that whole intellectual machine that's required to discover new drugs. Now, where does it leave us today? If any of you saw the Washington Post that was left on your doorstep, there's an article in there about the latest craze in drug resistance at the NDM1, which is New Delhi metallolactamase 1, which confers resistance to carbapenem. Carbapenems are one of the few drugs available that work against gram-negative bacteria. We've spent a lot of our time working against gram-positives because they're easier to kill. 2 basic classes of bacteria. Depends on what their cell wall is made of. Gram-negatives have this very, very, very thick coating on the outside of their wall, it's very hard to get drugs into them. So hard that we decided that it wasn't worth our while because there wasn't resistance in gram negatives. Let's focus on gram positives. We know we can kill them. The point being, this is complicated stuff. We don't talk about it in terms that people can understand. The concept of a drug becoming obsolete before it hits the market, I mean, that's counterintuitive, but it's absolutely true. It's just like when you drive a new car off the lot, it has lost its value, and it continues to lose value. That's how we have to look at antibiotics. So that's number one thing. We need to explain the nature of this therapeutic area a little bit better. Number two is within ourselves, we need to feel that same sense of mission that scientists felt during the Apollo program. I mean, we were racing to beat evil communism, so to speak, at that time. That was mobilizing. There's a war on infectious diseases, but that needs to spur an imagination. The way we talk about this, it has to be in a sense of excitement, a sense of mission, a sense of the fact that we're not just out there making profits, we actually cure disease. That's the other thing about antibiotics. You take it, it works with your immune system, you get better. You don't have to take it anymore, unlike chronic diseases, which are required. Vaccines are the same way, protect prior to getting the infection. So that was number two. Number three, there is no shortage of ideas. I looked last week, there's almost 400 preclinical programs globally among all pharmaceutical companies in antibacterials. There's almost 300 programs in the clinic globally for antibacterials. The problem is not ideas as much as the problem is money to test those hypotheses that the ideas are based on. So there needs to be an understanding of this costs money. We need to express that. We need to be willing to embrace different forms of funding, public-private partnerships, product development partnerships, things of that nature. These are sort of the new type Pfizer ideas that need to be generated. I'll stop there.
New PowerPoint 2010 or whatever. I have the old PowerPoint. And if this was a Mac, it would have turned over very quickly for Adam. So I'm the last speaker, and I'm going to be very, very quick and talk about a topic that was echoed throughout the speeches yesterday, and also a topic that I actually feel very, very strongly about, and that is promoting Pfizer as a healthcare company as opposed to simply a drug manufacturer or a drug company. And I think in the absence of any sort of major policy changes, this is going to be very, very important for us going forward. And I'm a little bit out of my purview here talking about this. I don't have any slides with statistics or graphs. I'm not going to be talking about economics or health reform. Let's see. Sorry about that. How did we do this? Oh, I see. I got it. Yep. Oh, I see. Yes. Perfect. Thank you, Eric. Anyway, so it's going to seem a little bit touchy-feely, and again, out of my purview of what I'm going to talk about, but I really feel strongly about this. And I noticed this 5 years ago when I started at Pfizer that we do a very, very bad job at talking to patients and communicating with them directly. And I still consider myself, even though I've been here for 5 years, kind of still junior and new, but for the life of me, it's amazing how the blocks and walls that are put up between patients and our company. And we come across as very, very detached from our patients, and when we do communicate with them, it's either through insurance companies or doctors, And it's always in the context of, at that point, cost, co-insurance, side effects. So the conversation is very, very narrow and can be very, very negative. When we actually do communicate directly with patients, it's in the form of DTC, which we're talking about conditions and products. And so at that point, we're first and foremost a drug company because we're talking about products. And then in the other major instance where we're communicating directly with patients is through our patient assistance program, which is wonderful, but again, it's through a very, very narrow line of communication when patients are in dire straits and they need medications, they can't afford them. So at that point, again, we're first and foremost a drug company. So it's no wonder why that we only have 7,000 fans on Facebook. I thought that statistic was very, very interesting yesterday when it was brought up. It just is evidence of the fact that we do not communicate with the patient community. But why is this important? It's not going to really solve our revenue problem. It doesn't do a lot for pipeline issues. But going forward, especially with healthcare reform and how things are changing, it's going to be very, very important to promote ourselves as a healthcare company because it'll be easy to insert ourselves in health policy discussions that go beyond the context of drugs. So what do we do? And I'm going to tiptoe into a little bit of how we do this. I think it would be very, very interesting to explore ways to create more touch points directly with patients that go beyond talking about products and conditions and talking about instead general health. And that basically allows us to avoid any sort of regulatory issues or legal issues about talking about products. So if we talk about general health, really start to show an active interest in patients' health in general, we can start to make inroads. So this is not easy to do. There are a million ways to do it, but I thought of a couple of different ways and borrowing from other industries and other companies about how we could do this. And one way is to create a pop-up Pfizer centers in very, very public places like shopping malls and airports. And Pfizer sort of explored this idea in when we promote our science and our products in conventions. And actually, Lauren Lillian helped me find these great images and prototypes of these sort of pop-up centers that were at least in the design phase. So I'm just going to show you a few. This is very, very large, but something like this that could be set up in, again, very, very public places. Shopping malls and airports come to mind. They're very, very public places. You have a captive audience. It's interesting, I was actually at a shopping mall in New Jersey just this past Saturday, which I try to avoid. Not New Jersey, that's not a knock on New Jersey. I live in New Jersey, but I really try to avoid shopping malls. They're not my favorite places. But it's very, very interesting if you're walking in, and it was very crowded, and all the men are sitting in the middle of the mall, just sitting on these benches. And this particular shopping mall put up flat-screen TVs, so they're just all sitting there watching television. I presume the spouses are in Saks or Macy's, and they seem perfectly happy. But if you can imagine something like this, very temporary, very cheap to do, or in an airport where we could set up a booth or some sort of center where we provide information, and we're touching patients, we're, in a figurative sense, we're providing information about general health, stress management, maybe travel health, and it would be very, very easy to do, and we avoid the roadblock of the doctor or the insurance company. This is a very small one. We could also do this actually in low-income school districts, basically a traveling science fair, and with school budgets being cut all over the country, this might be a very, very good idea, and when we could win some goodwill, and also show our commitment to science education and the scientific process at the very early point in the process. again, just a few. These are great images that Pfizer Oncology actually had developed for sort of similar types of pop-up marketing centers. And in an airport, you could put in one of the blood pressure machines that we have in 235 in the cafeteria. So just very, very simple, cheap efforts. And as a nod to my former life in commercial aviation, even airlines are doing this. Delta Airlines has a pop-up center that they do every winter near Carnegie Hall, where they basically give away Coke, hot chocolate, cookies to people shopping near Fifth Avenue. And you walk in, and they're not trying to sell you tickets. They do have a few computer terminals open with travel information, maybe a few coupons, but it's basically just to interact with their customer base. And very cheap for them to do this, and obviously they think it's worthwhile because they do this every year. And interestingly enough, I just noticed last week, walking up to Penn Station, 2 blocks above Bryant Park, Kellogg's has opened up a Pop-Tart store. It's crazy. So has anybody noticed this? It's 2 blocks up above Bryant Park, and the whole theme of this store is Pop-Tarts. You can go in. There's the history of Pop-Tarts. You can buy Pop-Tarts. It's amazing. So it's who knew? But if Kellogg's can do it, if airlines can do it, airlines are basically seeing, just like the pharmaceutical industry, they're not loved. But I bet you Delta Airlines has many more Facebook fans than we do. I mean, 7,000 for a company like us is very, very small. I would venture to guess most of those fans on Facebook are employees of Pfizer. So, but again, we have today very, very few touch points, and I think going forward, this could be part of a bigger idea of branding Pfizer as more of a healthcare company and making inroads into really developing personal relationships or closer relationships with the patient community in general. So I'll leave it at that, and we're going to start with questions.
Well, it's not every day you can talk about sex, bugs, and Pop-Tarts in the same discussion, or sex, bugs, and pop-up sex, pop-up bugs. These are big ideas, folks. That's good. That's good. I just make a point about Facebook. It's not the size, it's the motion. This time last year, we had 0 friends on Facebook, right? We couldn't even go to Facebook. So within, 9 months or less, we've gone from 0 to 7,000, which is probably more growth than a lot of other companies. Next year, we have more to do. Okay. So, Eric, I want to ask a question about the psychology of antibiotics. What do you think are the social issues when we deal with the giveaway programs at pharmacies now for antibiotics? You still have to get a prescription, but how does our psychology of antibiotics affect the investment need in antibiotics because we're overusing them? And how does that affect us?
Very good question. It is a psychological issue because we're taking something which I think is revered, which is really help save civilization as we know it and save countless thousands of lives, and we're treating it as a gimmick to get people in the door, into Walmart or whatever. Those of you who don't know, Walmart has been advertising free antibiotics or low-cost antibiotics, generics, of course. But at the same time, by encouraging that, what we're doing is we're developing the mindset that this is like aspirin. This is just something you'll get a free Aspen to take if you get a headache looking at our high prices or whatever you want to put it. But point being, all drugs are something to be, they're sacred. A lot of blood, sweat, and tears went into the development. A lot of money went into the development. They should be used appropriately when they are needed. And they shouldn't be treated as an afterthought. And I think that using antibiotics as a means, as a marketing gimmick to get people to come to your establishment, sends entirely the wrong message to the populace, that they forget the fact that these are life-saving drugs. So I think it's harmful. Besides the fact that yes, you need a prescription, but you're still contributing to the increase in resistance by contributing to the increase of non-discriminate use.
Thank you. Michael, I accidentally was watching Jon Stewart last night, and because there were so many TVs in my room, the odds of him coming up were pretty good, because I had to have them all on at the same time. And he said, CNN's motto is, if you're watching us, you must be in an airport. Actually, there's a lot to that. When you said that all the guys are going to, in a mall are going to go right to the screens. And what I'm wondering is, what issues do you see? I mean, why can't we have your pop-up store in one of those chair massage? Why can't we have a chair massage Pfizer pop-up in a mall, for instance? Because whenever I travel, I'm always looking for the chair massage people, right? And not the people, the massage. But and why couldn't we mix in an educational media background into these? What issues do you see? How do you think people would respond to us?
Well, I think we could do all of those things. I think first and foremost, though, the communication should be about patients' health, and not specifically branded to conditions or drugs, because we can't at that point, because there are all sorts of legal and regulatory issues. No, so we could do all of those things, and with sort of this kind of implied theme of, look, we care about health. That's our business. We make medicines, but also we educate people about their health and about diseases and treatments, and also about prevention. And when you do need us, we're here for you. But we would like to push off having you as a patient for as long as possible, with a very, very subtle theme. So with that in mind, I think sort of the main push should be for just general health information, prevention information. And I think if you're sitting in malls and airports are just the two that came up because people are captive. If you're a stressed out business traveler and you have 3 hours away, you could either sit at the bar, or for 15 minutes you could go interact with Pfizer directly, have your blood pressure checked automatically from one of the computers, or just sit at one of our pop-up centers and download information about travel health, stress reduction. And it's an at that point the patient is interacting directly with Pfizer, but not in the context of I need specific information about one of your drugs. And at that point, we're seen as a healthcare company and not simply just a drug manufacturer. So we could do all of those things, but it should be about health information and health care. That should be the overarching context.
Okay. So Dina, your toolkit point at the end, what do you think are our most effective tools right now, and where do you think we're not so hot in terms of our relationship toolkit?
I absolutely believe that Pfizer is acknowledged as having a lot of very smart policy people, and that we bring a lot to the table when we actually interact. And that's because our comments are extremely well written, they're very thoughtful, our briefings are always well prepared. You can't get more reference, top of the line empiric-based materials. I think the piece of it that we don't do so well is take that sort of empirically based policy, all those great, OODA loop inputs, and once we package it, I don't know if our packaging is appropriate. Are they, I talk about ear closers when you're talking to people. I don't know with the language we speak and the way we sort of take facts to people, whether or not those are ear closers. So I think how we deliver the information has to change. I don't think that we can be the only ones that bring that information to the table. Certainly we have to work much more in partnership with our patient and physician groups, certainly to be able to have those messages heard. So I would say it's all about the delivery, and we have a lot more to learn there. And certainly I think there's easy, low-hanging fruit improvements that we can sort of put into place.
And in terms of Pfizer Inc., to the outside world, do you think that, what do you think are the, if you had to make a change tomorrow in how Pfizer Inc. Deals with its relationships in the outside world with doctors and with patients, for instance, what's one thing you think would make us more effective immediately?
I think the first thing we could probably do is not espouse an opinion and actually just go in and listen to people. And that would be a huge game changer, because we do come in with our materials and our positions, but if we went on a listening tour and just literally listened and listened hard, I think that would make it would be a marked difference to how we've worked in the past.
Okay. Eric, one thing you didn't bring up, but you and I have talked about before, is the issue of biodefense. And of course, the history of antibiotics and their necessity in the world is now we're worrying about biological warfare and what we do about that proactively. And Pfizer has a role there. How do you see, what do you think we need to focus on to be a contributor in the biodefense area, given that the government has a whole new program they've proposed about accelerating that?
Well, it's a multifaceted answer. One of the things we can do is demonstrate our willingness and to demonstrate our value to the government parties by showing them what we really do, how drugs are really discovered, how they're tested, how their the safety profiles and efficacy and pharmacology and all that goes into development of a successful drug, and also show our willingness to do the work with them. But there needs, of course, to be a return of some type. Even if we don't make a profit, it's still going to cost money to do those sorts of things. So the willingness to put money up front for development, number one, is crucial. Number two is indemnification. We've run into the problem with BioShield 1 and 2 with respect to vaccines for anthrax, where side effects and adverse events and so forth. These are not trivial. These are drugs. Of course, they're biologically active. We do not work with molecules that are not biologically active. If they hit a target with a bacterial cell, chances are there's something very, very close to it in the human being, which is very difficult to work out a compound, just like chemotherapy for anti-cancer. That's the closest analogy I can make, is a cancer cell being a foreign invader in your body, which came from yourself, of course, being able to kill that without killing the host. We wrestle with the same issue with antibacterials. There are going to be issues of indemnification. Now, if you're going to rush, in the case of, say, there's an epidemic, and we need to produce a drug quickly, discover it, produce it, and test it, there needs to be an understanding that there is going to be some adverse events, and we need to be protected from that. The indemnification, willingness to spend the money, and willingness to understand that investments are necessary to spur research. I think those need to be made clear up front.
Okay, thank you. So, questions from out here? Yes, Art, Or you, Arthur, sorry.
Well, either is fine. So I have two questions, if it's all right. And the first one is for Dina, and Michael, and the second for Eric. So maybe I'll do theirs first, and then I can walk up and talk to Eric directly. So one thing that struck me about both of your presentations and the discussion has been a goal here is to do this listening, to hear people's views, right? And to think about patients in a more disaggregated way, so not like all patients are the same. But in light of what we heard earlier about new theories in economics, we've moved away from a concept that public policy and even firm behavior should be structured around the rational actor, and instead into a behavioral mode where, from a pure economics viewpoint, many people act irrationally. What that implies is that you're going to get a very broad spectrum of responses. So we don't want the how question, how do you deal with that, but what will Pfizer do internally when you get this whole gamut of feedback that really runs a very broad spectrum, a chunk of which many of you look at and say that's a bunch of people being irrational. And I can spend a ton of time figuring out why they've come to that position, but it's not going to get the company anywhere. So we're just going to cut those off and put those in the discard loop, and we'll respond to these other ones. That'd be one scenario. I'm just curious where you are in your thinking on this.
I'll tell you, a lot of those solutions, I believe, are actually residing with our business groups. They're working very hard to figure out that we know mass media no longer works, mass channels don't work. How do we harness social media? How do we harness database infrastructures to be able to talk more individually and to react more individually? So I do believe an awful lot of the way we sort of deal with policies are going to be grounded on how business solves those issues. They're expert at looking at individuals, but re-aggregating them so that individuality is preserved, but yet has a common core. They've gotten much better, just in general, in our marketing and understanding individual differences, and even how we market to physicians. They similarly have immense, differences in how they approach new therapies. So I would say we probably need to do a great deep dive in how marketing folks are thinking about this sort of challenge and pull in our IT folks, which have now been fully integrated in these functions, and see what they might be able to give us as far as best practices and lessons learned.
I would just make a few comments about the company has spent, and all the pharmaceutical companies have spent, massive amounts of money trying to figure out certain irrational aspects of patient behavior. Adherence is the biggest one. 50% of prescriptions are not filled, and we have spent every product team every year spends lots of effort and money trying to figure out how to get patients to talk about the conditions, but once they're prescribed the drug, to actually fill the prescription. And it's very we haven't cracked that code yet, and it's I think simply because, I think one aspect of that is as people are rational, and we haven't figured that out yet. But there's more listening to be done. Our context needs to expand a bit. If it's in laying the groundwork on a broader scale, possibly could be helpful. Listening to patients in different contexts instead of having a market researcher as pay somebody $50 to come in after work and ask them about why do you or do you not take your Lipitor. There's only so much information you can get in that small sort of venue, but you might pick up some other data points in other conversations in other contexts, and that's what this was at least my idea was about. It goes beyond setting up booths and in airports and shopping malls. That's just one piece of it. It's really expanding our role in healthcare, and then at that point, maybe we pick up some information that we didn't know was there.
I'll build on Michael's saying, only because I know Pfizer is investing a huge amount of money in the social scientists and really trying to understand behavior, and adherence is certainly one of those. But, what is the emotional sort of baggage that people take to the table? We all know that no one wants to be sick, so how do you get something that cures you? How do you sort of even accept the fact that you need something like that? There's a lot of resentment there. So I think we haven't really explored sufficiently the whole social science of what goes on with our medicines, but I know we're doing a lot of ethnographic research, and I don't know if people know what that is, but we actually will plant people in people's houses and, shadow them and follow them around to try to understand what is, how do they feel about the medicines? Is it fear-driven, or is it culturally driven, or to try to crack that nut. And I think this is a classic case where no one person or no one entity or no one individual can solve. I think this is probably an area very much ripe for public discussion and a perfect place where policy might be able to play a role, because certainly all those answers help drive public policy, and we could be really helping millions of people by being less insular and more open. So certainly something to think about.
Arthur, did you have a question for Eric? You want to come up so we can see you out of the lights here? This is for you, Eric.
Thank you. Is this good?
Yeah.
Yeah, okay. So with antibiotics, a couple of things you could add to your talk, and then a question. One is that FDA in recent years has been making the approval process more stringent around the non-inferiority delta. Because of course you don't test them against placebos, you do them comparator primarily against vancomycin. Mm-hmm. And FDA is concerned about over time approving drugs with declining efficacy. We know vancomycin's efficacy is declining. At some point we have a different comparator. And if we're approving drugs that have a non-inferiority, meaning for many patients they're better, for some they're worse, over time you could be approving very ineffective drugs. So FDA is tightening the screws. At the same time, infectious disease experts would love to have an arsenal of antibiotics that they rarely and selectively use in some staged sequence to reduce the rise of resistance. And we have a situation where large pharmaceutical firms have said, that's a nightmare. Like, you want me to invent and produce drugs that are locked away in a lockbox and then on occasion get used. So the only ones willing to take those risks are small biotechs, who ironically are in the worst situation to actually run the clinical trials, get the approval, and make these drugs to sit on the shelf to rarely get used. So that's my comment on, my God, from a business viewpoint, this is a total nightmare. So what is the future of this? I mean, do we just all die from infectious disease?
Well, first of all, thank you for coming up and for your question. What you've done is you've hit two of the most important aspects of what's going to determine success or failure of the new wave of antibacterials. The first one you've talked about with respect to superiority trials, that is huge for us. For those of you who may or may not know, the way clinical trials are done for antibacterials now is that obviously it would be unethical to not give a patient a drug and then give another set of patients the test drug. So when we do antibacterial clinical trials, we divide the group up, obviously. One group receives the standard of care, other group receives standard of care and our drug. And then we're supposed to show that the group that received both drugs achieved rates of cure in a superior way versus the group that just received the standard of care. That's almost impossible. In order to show any kind of efficacy signal, what you need to do is run huge trials. And even that doesn't guarantee you anything. For example, the compound that I worked on at Pfizer, trovafloxacin, you're probably aware of Trovan. I spent a lot of time on that. And Trovan, that was the largest clinical trial for an antibiotic in history. There was over 20,000 patients for that trial. And we still had, once it reached the market, we started to see side effects, adverse events, which ultimately resulted in the drug being restricted for use. Wasn't taken off the market, but it's very restricted at this point. What needs to happen is there needs to be a way of showing that non-inferiority, it still meet the standard. And what would help that is diagnostics that would enable us to differentiate patients infected with resistant strains, which are resistant to standard of care, versus patients who are infected with susceptible strains. Because that also makes it very difficult to tease out an efficacy signal in a clinical trial. So we need the diagnostics, and we need to get away from the superiority. The market will decide if it works or not. I mean, if people are getting standard of care, they're getting standard of care and our drug, we're going to see, some kind of a resolution there. So we need to get away from the superiority trials, number one. Number two, the niche drugs. Pfizer is made that strategic decision that we know that we're going to go to a low-volume, high-price market with antibacterials. And because physicians, the more unique the mechanism of action, the better it works, the more they're going to hold it back. People need to understand that that's fine, but we need to be paid for it. There needs to be some mechanism, whether it's a patent extension, where patent life is extended because the drug is not being used as much. We may find that as time goes on, therapeutic options diminish for current standards of care. The new drug that was previously held back finds more use. And in that case, we can take advantage of an enhanced patent life. There's some other mechanisms out there with respect to fine, we'll produce this drug, you'll use it in the last-ditch effort, but we want a tax break. We want a voucher, an approval voucher. We want something that we can apply toward the next Lipitor that we're going to be able to use to fund the money we're losing on the antibiotic that kills everything, all the bugs in the world, but you're never using it. So there needs to be that discussion, and there needs to be those mechanisms put in place, and those types of discussions are ongoing.
Okay, Linda, did you get all that? As our CDC person, did you have a question? Here comes your mic.
I was very excited to hear Michael's recommendation, suggestion about I call them kiosks. Mm-hmm. About 10 years ago, I proposed the idea of CDC health kiosks in shopping centers, airports, drugstores, just like you say, every place we could think of within reason. And it went over, as you can anticipate, like a real lead balloon. But the government is not going to do that. It's way too ambitious. It's too sophisticated. Everything about it is non-government.
However, you are in Second Life. Have you seen the CDC kiosk in the virtual world Second Life? We got to talk.
Yeah, yes, I have.
It's cheap. That's why you could do it.
Not only that, but the people who are doing Second Life are on the real fringes of CDC, and they're doing great work. But who in America goes to that? I'm glad you do. But Michael and I are after tens of millions of people, and they will come to this. The point I'm trying to make, and I'm going to make it quickly, the private sector will do something like this, and it's something that needs to be done, particularly in terms of the increasing need for prevention. Americans, as we know, have to take responsibility increasingly for their own health, not to get sick, rather than just kind of fixing it after we get sick. My vision was, building a little bit on Michael's, was a set of computer seats, if you will, with the screens and everything, in these, I'm going to call them Pfizer people pods for PPP. That's a nice logo. You get the design guys, and team with Apple and Google and Microsoft to really come up with, centralize it, the data to this, where they're able now to collect patient data, so it can be centralized so that all doctors and all hospitals can get it and all that kind of stuff. But I do think that it has to be more interactive in the sense that Pfizer, for example, and others, because it would be centralized, would not only be able to collect information from me coming up and, asking a question, anonymously, of course, because it's all kind of privacy issues, and we work with the lawyers to take care of all that. But then Pfizer would also answer questions. So it would be interactive. It would be collecting data, collecting even demographic, national data, statistical data on the changing status, health status of Americans. I mean, there's all kinds of implications with this. But I really wanted to compliment you. I think it's a brilliant idea. I think it's something we need. Somebody needs to do it. I don't think Pfizer can do it alone because even with all your vast resources, it's too expensive. And I think it would also benefit from being a collaborative effort with Google, with Apple, and then the creativity gets involved and all that. So I think it's a great idea, and I'll quit my job and come to work with you to do it because it's really a dream of mine. It's really a dream of mine.
I don't have any plans to leave Pfizer just yet, but any investors.
Thank you, Lynn.
Thank you. I really appreciate that.
One observation, and to build on that thought, I hear a lot of discussion about rational, irrational, as if the world was dichotomous. And I think the point was made earlier, Boyd's point, is that it really depends what window you're looking through. And so it's not a world of rational, irrational beings out there. There is a collection of thought around a whole lot of issues. And depending on how you ask the question and frame the question, you get different sorts of response. So the complexity is, I think you increase the complexity by just talking about rational, irrational. There are frames of thought out there, and it probably would be better to find some language around which you're capturing the way people think, and not sort of, because I'm not sure who's the rational being and in what context that person or that organization is rational. Everyone is pursuing to a set of responses. The other thing I would say about this kiosk idea, one of the things that's been sort of not stated here is that when you look at diseases, particularly chronic diseases, they're not symmetrical around the country. There are communities that have high prevalence of diseases. So the quick number I'll give you to sort of illustrate what I'm talking about, 80% of all the diabetics in America live in 8,000 zip codes, and there are 38,000 zip codes. And when you go to those 8,000 zip codes, what you don't see is any real infrastructure there to help people who are managing their diabetes. So the doctors' offices are outside those communities, the hospitals are outside of those communities. And so when those patients are looking for information, they have to, certainly in the poor communities, take buses and trains and leave work and all that sort of thing. So the opportunity to put kiosks not in train stations and airports, I mean, that's not who you're talking to. You're talking to people who are living in community. You got to put it in the community where people can access it. And I think that gives you the reach that you're looking for, and you're talking to very specific patient populations. Because again, you shouldn't assume that because someone has diabetes that necessarily in that community we're even going to see high levels of cardiovascular disease. So you have to understand the customer and then put in that community the information and tools that they need. And I think that's highly doable, and it would really be a game changer, because certainly what we see is that patients who need information in a timely way are not getting it.
Excellent point. Excellent point. One example, the Healthy Finland program that Pfizer is part of in Finland, they created stairs on sidewalks so that as you walk down the street, you can get a little extra exercise. And this created a whole lot of public attention, which then elevates the issue of health and access to health. And in Germany, the pharmaceutical industry, in association with the Health Summit there a year ago, it was in the winter, and they had this tunnel you could walk through into the building that was heated, that was still outside the building. And on the walls were demonstrations of drug discoveries like we have in the Pfizer building between 235 and 219. So as you walk into the building, you got a sense of what's been going on, because they took it to where you had to go instead of the other way around. Okay, last question from out there.
Thank you. More of a comment and then a caution. The comment on the kiosk idea, the Health Museum has been doing something very similar in this space, and they're looking for partners, so I would encourage you to reach out to them. They're now based in Atlanta, but I think that could work out very well. The caution relates to this concept of Pfizer becoming a healthcare organization. I think you're on the right track, but the caution is this. You're really talking about building relationships, creating an emotional brand. I think that you may be overly focused on the consumer end of the spectrum as opposed to the patient end of the spectrum. And what I mean by that is consumers and patients are really the same stakeholder group, but they're at opposite ends of the perspective. A consumer comes into the healthcare system only when they need to, and they get the hell out. For them, the healthcare system is a benefit. For somebody with a chronic disease, and there are 133 million people with one or more chronic diseases or disabilities, they're going to have that condition until they die. It's a very different perspective. They don't really like healthcare. That does not resonate for them. What resonates for them is the fact that you guys are developing new and better treatments that are going to help them live longer and feel better. That's where their inspiration comes from. Look at the American Cancer Society and their new ad campaign of the official sponsors of birthdays. Very effective emotional brand that says to a person, they're working for me, because of them I'm still here, and I'm going to continue to live and feel good. Pfizer is developing the products that are going to allow us to live longer, feel better. You have an opportunity, I think, in that space to inspire, not just simply be okay. So I think you're going down the right direction, but I would think about it a little differently.
Excellent point. Excellent point. Okay, join me in thanking our three panelists.
In keeping with our new calendar, we're going to go right into the wrap-up, and then we're going to start serving lunch at 11:30. So between 11:30 and 12:45, you can eat lunch here. During the period after we wrap up here, you can go anywhere you want and contemplate. And you have to be on the shuttle at 1. That's all. Have to. Or else. Okay. Okay, so for the wrap-up, I'm going to go through the yesterday's highlights. And then Greg is going to do the highlights from today and kind of weave the themes that he's heard over the last day and a half. And then basically we're just going to have closing remarks. So I've got just a ton of notes. We started off, obviously, with the bullseyes, which were really extraordinary. And then Greg asked us to really think about what would Google do. And then Megan brought it to another level of what would the Silicon Valley mindset be. It would be 80% of the time focused on your job, and then 20% looking for that creative idea. And then she also went into failure has the keys to success. And I thought that was really relevant. And that failure really does have the opportunity of showing you what worked and what didn't work and why. And that will lead you to success. Tom also talked about the 2 tier prongs of diagnostics and treatment as revenue streams. Arthur and Jamie talked about the patients as the really good source of data information. Jamie also said that Pfizer should think about being the healthcare company. Gary and Mark and Jim both suggested that fighting disease on moral terms is what you should be doing. And then Gary brought up the term clinical trial networks and capitalizing again on the patient advocacy groups. And then he discussed the value of human life and why we should get past the debate on cost and get back to the value of life. Jamie discussed creating an information war and know the difference that you make in someone's life and really take credit for it. And follow people over time to make sure you are really taking credit for the unexpected successes. And then last night, Ambassador Glassman discussed the considering communicating differently in different ways using third-party allies. And that was it. Over to you, Greg.
I want to make a large point first, and then I've got 11 things because everybody expected me to have 10 things, so I have 11 things. The two French words I learned a long time ago are memoir and reservoir, and I want to tell you why I think they're important. I said it yesterday. This isn't about making decisions in this day and a half and then going out and doing it. This is about thinking differently. In our memoir is our active memory, what you actively remember from something you learned or something you did. But in your mind, you have a reservoir of what you have experienced, and different parts of that come up when you need it that may not be conscious until you need it. So I'm hoping that when you think about these last 2 days, that you realize that many of the things you've heard today are not going to be in your active conscious memory in the next few weeks. As soon as you hit your email again, they're going to go away. But the whole point of this day and a half was to put a lot of things in your reservoir so that 6 months from now, when something comes up, this is going to come out of your reservoir and hit your head, and you're going to go, why didn't I think differently about this? I remember that discussion we had 6 months ago. So don't worry about how much of this you remember when you're talking to other people about it this week. Try to be open to relaxing into your reservoir and letting it come out when you need it. That's the whole point. So I have 11 quick things, and then I would want to open it up to any comments before we have a chance to breathe fresh air outside. The 11 things are this. Yenta pricing. That's what I got from Tom's discussion about the fact that we can do better by having a high-priced diagnostic be a screen for who gets a lower-priced drug than we're used to pricing, because we're matching patients to the drug. So we get paid to be a Yenta instead of a drug seller to people who may not need it or for whom it's not effective. So I think we need a Yenta pricing business unit. That's a joke. You can laugh. Arthur talked about new clinical trial models. Think about this. We're always worried about what will FDA approve, and we go in and we say, if we do this trial and we do it this way, do you like that? And the FDA is like the guru at the top of the mountain. They will only answer what you ask. They will not volunteer information. They will not help you. They will only answer what you ask. So if you go in and say, is this okay if we do it this way? They will say, yeah. And then they're waiting for you to ask them, do you think that's the best way? And if you don't ask them, they're not going to tell you. Now, if there's something actively wrong with it, like you're going to hurt people, they'll tell you that because they have an obligation to tell you that. Why do I say that? More and more trials now are not done in the traditional model, but are being done to show an effect and then go into the FDA and argue that even though this wasn't your standard randomized controlled trial, the result we got with this particular group is meaningful. Approve it. And they will do it. That's what Genentech did with Herceptin. They broke the mold. So we need to think about that. The whole melanoma issue that Arthur brought up, they needed to break the mold and say, you know what, we're not going to give people the therapy we know doesn't work. We're going to give everybody the new drug and look at progression-free survival, and then you tell us why you're not going to approve that. Health information technology, Arthur mentioned that there were 4 models. These are top-down models. That's not how it's eventually going to end up. When we get the technology out there, just the way we did with cell phones and wireless frequencies and all that, and the internet, people will change it. So the key is, how fast can we as a company help get health IT into the patients' hands and the people's hands, and let them tell us how they want to use it to communicate with each other and with us. And that goes to an overall point that's been made. People and patients are enormous sources of data, whether it's consumer products and animal health products that we sell, or the Lipitor, and now with the acquisition today of King Pharmaceuticals, painkillers and opioids. We are not listening in the right places because we don't have the structure set up to do that. We're listening to people who listen to people, but they don't do a very good job talking about doctors. Doctors don't spend more than 10 minutes listening to you. If we rely on them to talk to us about patients, we're not listening very well. That goes to the question of what is the difference we're making? How do we measure that? It's not prescriptions. It's prescriptions effects that people report. And how do we create a structure to do that? The spaghetti tower. We need more spaghetti. We don't ask for more spaghetti. What is the spaghetti we're not asking for? We're not asking for more friends in the right way. We need to go out and get more friends by what we're doing, not just by what we're giving them in terms of support, but getting them to like what we're doing. We need to go out and get more chances. That goes back to my clinical trial point. Don't just follow the rules. Set new rules by showing the result. And we need, the acquisition today is more spaghetti. It's okay. We have cash. The whole corporate America is sitting on a lot of cash. If we think that we need more spaghetti in terms of more products, we should go get them. Because as Adam said, which is my next point, we have to be rich, optimistic, and think big. Because whether we like it or not, we're the biggest. And if you're the biggest and you're not rich and you're not optimistic, you can't think big. So our future has to be built around what I call Adam's world. Disintermediation. I saw a commercial last night for the Humana Walmart new program for prescriptions, and it's going to save you $450 a year on your drugs. It's going to cost you $14.95, not $15. And they had the guy with the dog fishing. And I thought, this is just like the drug ads with the dog and the pretty woman on the beach at sunset talking about your antidepressant drug or whatever. And yet, the way we can communicate the benefit of our drugs is very constricted. But the way they can communicate the benefit of their health plan is unrestricted. So they can say, we're going to give you the world on a string for free, and never answer the question, who's going to pay for that and how? We have to deal with that piece of it, and we're not going to deal with it without taking apart some of the system that exists now. Just as Walmart is going to take apart the insurance plans and the insurance system and the reimbursement system and come up with a whole new Walmart model. Michael's point about taking it to the streets, I think is an excellent point. A lot's been said about that. We tend to engage the industry at industry shows. That's not helpful. We need to engage people at people shows.